I think Suni has some construction kind of stuff going on at her place. So I'm going to actually, you're going to have to suffer through me talking through all the slides, but she had just as much to do with all of this as I did. Our main disclosure is that this work was funded by the Agency for Healthcare Research and Quality. It's an R13 conference grant. And then I also wanted to acknowledge our co-conference leaders here, Natalia Pachurkowski at Rochester General Hospital and Corey McDaniel at Seattle Children's. They were a lot of fun to work with, and definitely their expertise and dedication to this project made it possible. In particular, they brought among many other things, but it's a community hospital perspective. Natalia is one of the leaders in community hospital medicine in the US, and Corey has also done some great research in that area. Just a bit of background for our conference series. This is probably well known to you, but good to say again, pediatric hospital medicine is a very young field, at least in the US. Was only recently recognized as an official subspecialty. Most investigators are junior and mid-career. As a result, there's a lack of randomized trials to guide clinical care. We just haven't had a chance to do very many yet in our early stages of PHM. And I don't know about you all, but my experience when I'm on service is that it's extremely rare to be able to turn to randomized trial data to guide the clinical decisions that come up on a daily basis. So there's an opportunity for our young field to try to do more randomized trials and improve the care that we're delivering for hospitalized children. The aims of our grant and project were, number one, to identify and prioritize randomized trial questions for children hospitalized with common conditions. Number two, identify facilitators to community hospitals participating in these randomized trials. This is true in the US. I believe it's true in Canada as well. A large proportion of children who get hospitalized are not hospitalized in children's hospitals. They're hospitalized in community hospitals. And so especially kids who have common conditions. And so if we're really going to be serious about getting trials done in this population, we really need to figure out how we can involve community hospitals in trials. And obviously, you all have been successful in that. I can think of at least one or two trials in the Ontario area that that are great examples. So our conference series is really three virtual conferences with some work beforehand and in between. And that's how we accomplish the aims that I just laid out. So you'll see this figure again in the coming slides. First, it was really important to us to have a diversity of backgrounds and perspectives in our conference participants. That was definitely a priority in participant recruitment, and we're really proud of the group that we assembled. A total of 46 individuals from 30 different institutions participated in our conference series. We successfully recruited parents of hospitalized children, children's hospital and community hospital pediatricians, nurses, pharmacists, biostatisticians, and trialists. Specialties represented included hospital medicine, general peds, emergency medicine, infectious disease, and critical care. Of the participants who shared their demographic data with us, almost 2/3 were women and 20% were non-white. This is a full list of the conference participants. Sorry about the small print, but there were a lot of people, and you'll see some familiar names on here. Sanjay, Peter, let's see, A.L. Cohen, maybe I'm sure is well known to you all. Anna Heath, a statistician at Sick Kids. She was really great to work with. We were blown away in general by the enthusiasm of the community to help move this work forward. And I think that speaks to the potential of our field to tackle more trials with a bit of direction and the right resources. So our first step, if we're going to try to come up with randomized trial questions for common conditions, is to say, well, what are the common conditions? So we utilized publicly available data from the Agency for Healthcare Research and Quality. and this is for a US population. And far and away, the most common reason for pediatric hospitalization is a child's birth hospitalization. Um, After that, it's common respiratory illnesses. And these are the 10 conditions upon which we focused our trial question generation in this work. During the pre-conference phase, a medical librarian performed structured literature searches to pull guidelines and systematic reviews for those 10 most common conditions that lead to pediatric hospitalization. And then small groups of conference participants used those resources to identify evidence gaps and generate potential randomized trial questions for each condition. During Conference 1, we led participants through a modified Delphi approach to rank the questions generated during the pre-conference period in terms of importance. This is the framework through which we asked participants to think about importance for each trial question. To what extent will this RCT answer a question that patients and their families care about? So patient-centeredness, improve the patient experience, improve important clinical outcomes, increase efficiency or reduce variation in care delivery, improve safety, and promote diversity, equity, and inclusion. We then had an interconference period during which we distributed trial questions from Conference 1 via a national pediatric hospital medicine listserv in the US for public commentary and further scoring. Then during Conference 2, we led participants through discussion and small group work, again, the modified Delphi approach, this time to consider trial question feasibility, culminating in participants ranking each question in terms of both importance and feasibility. And in total, we generated 63 randomized trial questions scored from 1 to 9, where 1 is the least important and least feasible, to 9 being most important and most feasible. This is the feasibility framework that participants used. First, how straightforward or not would it be to administer the proposed intervention and control group requirements at your institution? Are the intervention and controls doable at your institution? Secondly, in your usual practice, how commonly do you care for patients who would be eligible for this trial? For example, weekly, monthly, yearly? And then what challenges, if any, do you anticipate for collection of outcome data in this trial? Displayed here in a PICO format are the 5 highest scoring questions, which were as follows. Among children hospitalized for cellulitis, a comparison of treatment failure for those randomized to short versus longer courses of antibiotics. Among children hospitalized with pneumonia who also have medical complexity, a comparison of broad versus narrow spectrum antibiotics with clinical deterioration being a primary outcome. And then 3 related to urinary tract infection that differ based on the age predominantly of the subjects. The first 2 compare short versus longer course of antibiotics and look at treatment failure. The third UTI, but 5th overall question focused on children with UTI and bacteremia, and then comparing a fixed duration of antibiotics to a situation where you transition from IV to oral antibiotics based on the child's clinical course, again, looking at treatment failure as a primary outcome. These are the next 5 highest scoring questions in terms of importance and feasibility. For children hospitalized with pneumonia, comparing oral antibiotics from the time of admission versus IV antibiotics from the time of admission, and comparing time to recovery between the 2 groups. For children hospitalized with asthma, comparing readmission or ED revisits for those randomized to prednisone versus dexamethasone. For febrile infants, looking at caregiver satisfaction for those who have telemedicine follow-up versus in-person follow-up. For children hospitalized with gastroenteritis, comparing lengths of stay for those randomized to IV hydration versus nasogastric or subcutaneous hydration. And finally, for children hospitalized with mood disorders, looking at behavioral health security activation or use of restraints, and comparing standard care to an intervention that has healthcare team de-escalation training. For conference number 3, we used the nominal group technique to identify strategies and solutions for successfully conducting randomized trials in community hospitals. Through multiple rounds of individual brainstorm, sharing and discussing of ideas, rating ideas, we generated 116 total ideas and then narrowed that to a top 10. These ideas were organized into 3 categories, all in service of the goal of facilitating community hospital participation in trials. First category was centralized resources, and some of the ideas were to centralize infrastructure, utilize telesupport for study procedures, research network collaboration, where a certain percentage of those hospital collaborators are community hospitals, and then statistics and writing support, again, in a centralized setup. Proposed policy changes, prioritization of funding for studies that include community hospitals, a mandate for community hospital participation in funded studies, national IRB revisions that allow for the ability to include sites that maybe don't have a local IRB, streamlined and integrated data transfer and access without charges to the community hospitals. From a research design standpoint, considering hospital level randomization and interventions as opposed to patient level, that was seen to be more feasible for community hospitals. Maximizing data collection efficiency by asking multiple questions at once and collecting data for multiple trials at the same time. And then consideration of integrated consent, whereby providers can obtain consent within the same processes of caring for the patient. Certainly, this work has many limitations. The first one is that these are not the only important and feasible RCT questions for children hospitalized. Undoubtedly, there are additional questions that are maybe less common conditions or questions that are pertinent to activities that are not necessarily condition-based. So you could imagine RCTs comparing processes like transitions of care, that wouldn't have really come up in the framework that we established. Secondly, these questions definitely need more refinement before they are ready for someone to do the trial. And so, examples would be making sure that this is the right primary outcome. Our groups have some suggestions, but power calculations and all of that will play a role, certainly. Third, the majority of our conference participants were physicians. Obviously, we did have individuals from other backgrounds, but it should be noted that I think we had maybe 4 parents, for example. So we were really doing our best to call on them with each trial question and get them engaged. But at the end of the day, it should definitely be noted that most participants were physicians. Our importance and feasibility frameworks are not validated. They're based on some prior work and prior frameworks, but not validated. And then lastly, our feasibility did not include formal sample size estimates and power calculations, just kind of outside the scope of our work. And obviously those would have substantial impacts on study feasibility. Implications for this work, we identified important and feasible randomized trial questions for children hospitalized with common conditions. It's pretty neat that these conditions that we chose are responsible for about 3/4 of pediatric hospitalizations, at least in the US. So large population who could potentially benefit from this work. And lastly, we believe this work can serve as an evidence-based foundation to guide investigators and funders in conducting impactful trials in pediatric hospital medicine. And I will leave it there and would love to hear any questions, critiques, comments, etc. Thanks.
Great, thanks, Eric and Suni. So we have some time for questions. Really interesting work, and liked how you incorporated patient input there, but also diversity in terms of clinicians. I had one question just while waiting for others. I've just been reading along about what's happening in the US about community hospitals and inpatient care and closures. And has that changed the relevance of partnership with community hospitals for research in the US? Because it sounds like there's been a huge shift of inpatient hospitalizations to children's hospitals away from um, community hospitals. I totally don't understand the nuances, and I know that there's differences in how hospitals are designated, but I wondered if that might change the landscape of doing RCTs, given that children are being cared for in children's hospitals primarily from my read as an outsider, but just wondered if you had any insights or comment on that.
Um, I'm happy to comment because I was looking at Joanna's
Yeah.
paper that she recently published like just yesterday, and it actually looks like, Sanjay, that the volume in freestanding children's hospitals has been pretty steady, and the overall volume of hospitalization steady. But there's been a shift to a lot of like small units, mainly in rural hospitals, closing, and that shift going into urban hospitals that aren't like children's hospitals necessarily. Um, and our goal, and Eric, correct me if I'm wrong, was really just thinking about how to get broader participation in trials, not necessarily like urban versus rural. So I think these findings would still apply. There are just sites that aren't as well resourced to participate as freestanding children's hospitals tend to be. And we're just thinking broadly about how to better support that work so that trials could be conducted more quickly with more sort of generalizable populations than maybe freestanding children's hospitals tend to attract and serve. But yeah, it's a real, I mean, it's definitely become a really big problem as these smaller units in rural areas close and families have to drive super far for pediatric care, and even like giving birth. Like a lot of maternal care is closing down in those sites as well. So but
Okay.
they're just not financially incentivized to, stay open. So
Okay, thanks for providing insight. Peter?
Thanks. It's an amazing amount of work you've done. It was nice to be a part of it. I guess one question is, as from the network standpoint, like with our prioritization, we've really tried to, use it to help incorporate us moving forward from a project standpoint. So I wasn't sure in terms of prize, in terms of how to envision like how prize as a network utilizes these findings in terms of how they will or will they be part of some like pushing others to focus on these topics, or how you envision it being incorporated at sort of a bigger network level.
Suni, do you want to? I feel like
yeah,
you're again poised to answer that.
Well, Eric and I are submitting like a big grant tackling 3 of these questions right now, sort of through the network. Leveraging this idea of like a platform design, increasing efficiency by kind of looking at multiple conditions and multiple questions at once. And I think, Eric, maybe you plug this idea even, and I think we did in the paper and when disseminating it, that these are just these are the important questions to answer. Obviously, through the network, we'd like to, since we have the right people and resources, do them as trials, but people could also do them as observational studies to just move the evidence base forward as well. So I think we're just trying to encourage it on all fronts, just, set a framework that these are important questions to answer however folks can. And then the network can obviously help facilitate study design and recruitment for anybody that wants to conduct them as trials too. I don't know,
And
Eric, other thoughts on
well, I'll
that?
just
But
add.
also,
Go
yeah,
ahead,
that's
Suni.
that small group thinking about next steps too in conference 3.
Yeah, and I was just going to add, I think obviously we have a vested interest in utilizing these findings in prize, but I think this work should hopefully bolster the efforts that other individuals are doing outside of the network. So, for example, I'm aware of at least, one person's career development award where they are citing this work to say that their question, they were already kind of interested in a certain question that's on our list. And so now they can cite this and say, yeah, a multidisciplinary stakeholder group identified my topic as being pretty important. And I think that'll be helpful as pediatric hospital medicine further establishes itself as, a bona fide specialty with great researchers who have important ideas to move forward.
Mhm. And then one quick follow-up question. So, is there an avenue to feed these back to AHRQ or NIH just about sort of prioritize in terms of calling for funding for some of these? Because I know in the UK, the NIHR has a natural sort of feedback where prioritization exercises get used for directed funding calls. And we've struggled in Canada to feed them back for funders, but I wasn't sure in your context if there's avenues for that.
We did, I alluded to, Peter, in our third conference, we did some small group work where Eric led work around like what would our next steps be to get the trials going. And then I met with funders from ARC and NIH and PCORI. The main question we posed to them was sort of how do these questions align with your current funding priorities and what opportunities do you have currently that might support them. And, they pointed us to directions, including the one that we're pursuing right now with PCORI. I think that I don't know how common it is for these funding agencies to like anchor on particular conditions or fields, but broadly they all express that research around children, it's like a priority population for AHRQ and many NIH institutes in PCORI. So yeah, we didn't pose that question of like, would you put out calls specifically on these topics? But that's a great idea as a follow-up, especially to ARC. I think there's sort of this intersection of what these institutes' missions already are, where ARC funded the conference, but they're not a clinical research oriented agency. So it gets a little bit tricky, but yeah, that's a great idea. And it's even more limited here, that bi-directional communication, than it is in Canada, I would say. So we definitely struggle with the same issue.
There's communication, just no action. I mean,
Right.
in the UK group, Gabruki, they prioritized an exercise, and I think two or three of the questions that ended up becoming NIHR funding calls directed to the PICO questions that were felt to be. I mean, it didn't mean that they got like it was the open competitions, but they're directed questions based on exercises, and so seems like a nice model. So I wasn't sure if it'd be nice to
Yeah,
just
it's a great idea. I think we'd have to honestly like map each question back to the right agency and take it back to them. Because of the way NIH is structured. And we've also had trouble, NICHD, which is our like child health and development funder. The way they are structured, they don't really have a home for hospital medicine. They have a home for critical care, but not hospital medicine. So that's been another tricky kind of needle to thread. So we'd have to like take each question and map it back to like which system-based agency might put a call out for it. But yeah, it's a very good idea to at least make them aware that we did the work. And so this might be an anchor for like picking what to put a call out for.
Thanks.
Carla, did you have a question? I saw your hand up before.
Yeah, I think it's a pretty quick one. It's about the most common conditions that you see on the ward, and the fourth common was a pretty large group mental health conditions, and so I was just wondering what the breakdown of that was, and then could you use that to potentially target like specific questions or like specific grants? Yeah, that was my question, just kind of like having a better sense of, is it eating disorders? Is it anxiety, self-harm?
Yeah, thanks, Carla, for that question. I don't have the numbers in front of me right now, but my recollection and just kind of experience on the wards is that the vast majority of that bucket are, suicidal ideation or intent. But we did, as I recall, we did lump a couple of common categories together. I think anxiety being one, maybe was in the top 20. And so that kind of got wrapped into the that mental health category.
Yeah, that's what I remember, because in the small group, we did those breakdowns for people. And it was, like major depressive disorder or generalized anxiety disorder with suicidality usually. And that is a rapidly, because we also, I think in our paper, right, we trended it over time, and it's moved from like 11 to 7 or 8 to 4 now in terms of the ranking. So it's definitely an important one. But the biggest like interventions are really like health system interventions around that, as opposed to clinical trials, I think, which is
And population level, right? I mean,
yeah.
taking better care of our citizens, and yeah, so I think it made it hard to develop questions for that category. I think we maybe only had 3 to 5 questions for the mental health category. Maybe part of it's because as hospitalists, at least in the US, our perceived ability to kind of move that needle might be small. We're kind of at the end of the pathway that leads kids there, and most of the interventions probably need to be a lot more upstream. But we did kind of focus on what can we do while they're in our hospital to make their experience better, to make their care better.
Thank you. That's great.
Any other questions from anyone for Suni or Eric? Okay, great. Thanks again, Suni and Eric, for